Good morning, everybody. Welcome. Looking forward to having this discussion today on treating the heart of gambling disorder. This is such an issue that's become near and dear to my work over the years, and happy to be sharing this with you over the next hour, hour and a half. So, as has just been discussed, I am a licensed psychologist, been working with gamblers for about 25 years now, and I wanted to throw out my contact information there. I love this material, so I'm always happy to discuss further. Feel free to reach out to me with questions and things during the presentation. We'll have some question and answer at the end. If you're like me, I always think of things after the presentation, so feel free to reach out afterwards. So for today, we're going to cover a few things. Key points I want to get to is identifying the role of emotions in the development, maintenance, and resolution of gambling disorders. I'll throw out some of the parallels to substance use disorders as well, as they are similar or different since we have some co-occurrence of these disorders. Identify the importance of emotions in deepening the therapeutic alliance. And participants will be identify 5 key emotions, which will include fear, anger, and grief. And the emotional element often gets overlooked. So we're going to try and dig that in a little bit deeper about how to work with that role to maintain a whole person approach to get back at the heart of change making. So for a quick overview, so where we're going to be going in the next bit of time, where have we been? Just a sense of context for our work. Where are we at now in this current state of addiction and recovery and challenges of the world? What's really our goal in working with a client, in working with our best practices, et cetera? What's the role of therapeutic alliance, emotional balance, and how to find that balance and maintain that balance and help the people that we're working with on a daily basis to stabilize that balance and onto a more regular basis. So I always like to start with ourselves. For just a moment, take a moment to check in with yourself. Do I believe that individuals can change? This seems like an obvious question. Of course, the answer is yes. The work that we do is predicated on this answer of yes, the work we do is because we believe individuals can change. It seems like an obvious question, but very often today, in today's world, it's not as obvious as that. Do I believe that they can change quickly? Do I believe that they can actually change their opioid use along with their gambling use? Do I believe that you know what I mean? So there are a number of elements here that could be hidden under that as a belief that they can't change. That they can change this, but they can't change that. So checking our own beliefs about the possibility of change really is critical, because if I believe that they can't do something, they will not be able to do it. I won't be able to guide them to that possibility. Okay, so these are our personal beliefs. So what are some of the fuel of our personal beliefs, behaviors, and motivation? And do I have a sense of what motivates me? And just giving a small hint there, emotions are very much the fuel that drives motivations. So am I able to experience a range of emotions? Or are there some that I've labeled as bad? It's like, I don't get angry, no fear, whatever it may be. Now, where the heck did I develop these beliefs and emotional patterns from my past? It didn't happen yesterday, didn't happen the week before that. So what went on in my life that helped me to guide these beliefs? Because these beliefs and emotional patterns in myself as a counselor will affect where I can bring the person that I'm trying to help along the way. Do I feel able to achieve the things that I want? Do I have a sense of personal hope and vision? Same principles. If I am not able to identify those in myself, it's more challenging for me to do that for others. How do these beliefs affect how I treat individuals with substance use disorder and gambling disorder? So my beliefs The more I become aware of them, the more I can understand how they affect my clinical practice, the more successful I can be in helping others to get there. So this first part is actually quite important. So consider a couple of points for the following as part of our discussion in the next hour and a half. For this presentation, addiction is being used to be inclusive of both substance use disorder and behavioral process addictions, such as gambling disorder. Although, of course, there are other process elements that could be considered. Addiction is being used as a relatively severe substance use or process addiction. So we're not talking about substance use disorder mild or a mild gambling disorder. We're really talking about folks who have developed problematic behaviors and gone down that process a little further. So a couple points to just consider that we'll talk about over our time. Addiction is a disease of hopelessness. Addiction is a disease of shame. And addiction is a disease of isolation. So think about that for a moment. Catch the emotional tone and elements of these 3 points. So let's begin to think about that a little bit as it goes on. Some of you may be familiar, there's an old story of the blind men that come across an elephant. And the first person finds the elephant and says, and touches the elephant's tusk and says, aha, I understand what an elephant is. It's like a spear. And the next person touches the elephant's trunk and he says, ah, I understand what an elephant is. It's like a garden hose. The next person touches the ear and says, oh, it's like a leaf. Next person touches the side and it says, oh my gosh, it's like a wall, or like a tree trunk, or like a rope. So each of these persons is right in their perception of the world. However, their perception is only limited to what they were able to perceive, what they were able to see at that time. So the larger question becomes, what if we were wrong? What if we were wrong? We get so focused on our little narrow piece of the world, but very often there's a larger picture that every once in a while it's really important to step back and see so that we can recalculate and redirect to make sure that we're headed towards the goal that we're trying to get to. So as we step back, let's take just a moment to check in with our history. This will be very brief, but just to get a quick flavor of a couple of things here that have happened in our history. You know, first understand there was a time in 1895 where you may have heard of Bayer, you know, the best known for aspirin. In 1895, they were selling Bayer heroin. Bayer heroin. It was well known. It was used for cough as a cough suppressant. As you can see there, the kids just love it. So it was very it was a hit at the time. But we've learned a lot since then. So maybe they were wrong. They may have changed things since then. So we moved along to the 1990s and we found Coca-Cola, which was actually made, and here's an actual recipe from the coca leaf. So we found it very stimulating. And we've since learned a little bit from then. It's no longer made with cocaine. In 1940, our physicians were telling us out there that we need to use the cigarettes, that these are the best cigarettes you should be using. They were our lovers of cigarettes at that time. It is your throat's protection against cough. We learned a lot better since then. 1966, we've learned that benzodiazepines were advertised as mother's little helper. You know, just use this pill, use this sedative, and you will no longer be stressed and you will love your kids again. Okay, stress relief treatment. It is now, of course, one of the major associated elements with their overdose deaths. In 1980, the New England Journal of Medicine had the famous Porter and Jick study. It says addiction is rare in patients treated with narcotics. It says blah, blah, blah. We conclude that despite the widespread use of narcotics, the development of addiction is rare in medical patients with no history of addiction. By the way, this is a letter to the editor. It is the entire study. You just read it. Okay, so just a note here on the side. This article, by the way, has since been referenced around the world, recommended that people should consider the work of Porter and Jick. It is an extensive study that was persuasive and demonstrated that it's an exaggerated fear that people will become addicted to opioids that's basically unwarranted. doing a quick check across the major literature sites, this article was cited by 161 professional studies in PubMed, 207 in ProQuest. Google Scholar has that all the way up to 1,400 references as of last month. Okay, so this study has been cited around the world to say that we should not be, we should be using pain management because it is safe and effective. And in fact, pain is the fifth vital, became the fifth vital sign that we should be assessing everyone for pain. We should be prescribing this opioid, which is non-addictive and could never harm anyone. And maybe we've learned a little bit since then. So think about this for a moment. Just like the elephant example, there are places in which our history, we've made some serious mistakes. And it's important to learn from those mistakes along the way. And so as we think about that for a moment, it's easy to say, well, that's the past, but the lesson is still the same. When do we step back and make sure that we're staying on the right path? And that's really our focus today. How do we begin to pull our heads out of the sand for a moment and step back and say, what if we were wrong? Where do we get our best effort? Where can we get our best, place our effort to make the most substantial change? Now, obviously, we wouldn't be making any of those mistakes of the past today. So let's just consider for a moment where we're at today. Right now, we have COVID going around the country and around the world. We're developing more and more research out there saying in the last year, year and a half, we have had a dramatic increase in substance use disorder, gambling disorder, and a whole host of other addictions. As we move through the COVID process, there is widespread ranges of fear, grief over our loved ones who've been lost, fear over those that are in the hospital, the loss of joy, isolation, relationships in isolation. We're not going out to meetings anymore. We're not sitting around in group therapy anymore in the same manner very often. As we've moved from live meetings where we can meet and shake hands and hug each other to our video screens alone in our houses. So there's been a lot of changes in this, and which is considered to be a major piece. Again, the emotions as the driving force of some of the changes that we're seeing. And at some point, as we move our way out of the COVID situation, as we move our way back towards relationships and back into the therapy rooms, we need to begin to uncover and address some of these changes that have been made, and how do we respond and continue to change with those times. And to what extent does telemedicine and online work continue as a part of that, or change yet again over time? Now, you may have heard this thing going on about an opioid epidemic. So the CDC most current data, you can take a look at the number of overdose deaths there. Actually, in the last, as I mentioned, it's certainly been going up in the last year or so. This is pretty up to date. But despite a whole lot of effort that we've been putting in recent days, there are millions and billions of dollars going into addiction treatment, largely speaking, in the last few years, but we really haven't made a dent in the overdose death rates overall. So I come back to this point, even today, are we spending our efforts where they will be most useful? So there is certainly always a lot more research out there on the SUD side. So paralleling that and learning from these lessons along the way as we continue in this process, as many of us are also working in multiple settings. We've gotten a heavy emphasis on opioids for the past few years, but when you stop and just take a quick scan over the numbers, when you look at the populations affected or the healthcare costs, opioids are really not the bigger drivers of death and costs and hospital costs. When you consider and compare that to things like tobacco, alcohol, marijuana has been on the rise. Certainly gambling has continued to be on the rise. So begin to think about how pieces all fit together and where do we put our larger efforts. Now, for us in the gambling world, alcohol is also a really significant one to not be forgotten, even though it's gotten forgotten by some of the funding sources. So consider the co-occurrence of alcohol, as well as what can we learn that will address the complex person and addiction processes as they develop. Now, just a quick other word here of some other things that have been going on around the world and the funding and the emphasis lately. How do we begin to have routine screenings at medical visits? So in medical visits, it's expert. We've been making strides, certainly, probably varies by state, but I know certainly in our state, we've been growing at making sure that STD treatment programs also at least screen for gambling, even though there may or may not be a formal good system to then refer them to within the program or without, but there's a growing system there. We have evidence-based practice. Evidence-based practice, you can't go anywhere these days without hearing about evidence-based practice. Evidence-based practice. We've been focusing on how many medications are offered at your program as a metric, as an outcome. In the substance use world, we've been talking a lot about the placement criteria. Well, does anybody know what the placement criteria is for the gambling disorder? And has anyone seen it or used it? There actually is such a thing. And even if you are aware of it, are you aware of where there's a continuum of care for gambling disorder treatment, or is it primarily IOP and outpatient? Okay. What do you do with the clients who are severe that they need a residential level of care or hospital level of care, for example? So you've got the full levels of the series of continuum of care. There's been a lot of focus also on paperwork. The funders have been driving this particularly on the timeliness of notes, the quality of notes, the timeframes of treatment plans, and we're going to take back your money if you don't do all these in a timely manner. I won't name any names, but I have hands in all sorts of places, and I have heard of programs that are getting 95% paperwork compliance, but 90% AMA rates. So counselors are sitting in their offices doing all this paperwork, and the clients are walking out the door. We're not spending our focus in ways that will serve the clients and get them to stay, get them to change. Similarly, one of the ones I love is we're trying to adopt some of the metrics for quality of care from the medical profession. So had an insurance company ask about the client's BMI, to which my response was, BMI? Obviously, that must mean something differently to you than it means to me, because it means nothing to the conversation that we were having about that particular disorder. But yes, indeed, adult BMI, which does have certainly health consequences, but it may or may not be the immediate focus of some elements, for example, on my gambling disorder. If I was to take a look at a co-occurring eating issue, that's another conversation. So how do we begin to, again, it's very easy as our funders push us to shorter lengths of stay, to more community-based lengths of stay, types of approaches to stay, and documentation. How do we remember, where is the client in all this? What is meaningful in treatment, and how do we keep our finger on the pulse there? We are the professionals that are working with the individuals. So the funders are going to push what they push, but it's our responsibility to help the individual that's in front of us. Okay. So I'm going to pull a couple of articles along the way here, just to kind of bring a context here again. So bring a bit of research context to the environmental context. So this study is a little bit older, but they catch something really important here. I love the question that they pulled. They said, what was different on your last quit attempt? Okay, what was different on your last quit attempt? What allowed you to get into this thing called recovery, however you define that? And what they identified most commonly was their 12-step affiliations. Immediately following that is good support. So you've got about 40% are identifying some sort of relational element as central to their change process. Okay? Remember I said addiction is a disease of isolation. And so the converse is also true. The more I can help individuals to get connected, the better I can support them. Now consider my role as a counselor is about developing a relationship. The change that will occur is in the context of our relationship. Now, of course, there are many other things that impact change, such as insight, helping to feel prepared and competent, potentially more intensive treatments such as residential rehab. That was actually even lower ranked, even though many of them still attended such things. Okay? But what is happening at a residential rehab? One of the first things that's happening is the deep relationships that are built very quickly. Okay? So throughout this series of changes, the relational elements are particularly important. I want to also point to Faces and Voices of Recovery is a national agency for drug and alcohol recovery. They did a survey of over 3,000 individuals with an average of 10 years in recovery. This is a growing principle to say, let's stop looking at our sick people to figure out how to do things right. Let's look at our well people to figure out what worked for them so that we can help to devise a roadmap about how to get there. So key elements to consider, the vast majority identified themselves as in recovery, and notice it's an active verb. So notice they are actively doing the steps and work of recovery, whatever that means for them. Now, fewer percentage identified it as a past tense, recovered. I got this. I don't need to do anything else anymore. Okay. For most, the pathway is identifying that I am actively working on my life and my life growth. 95% had attended a 12-step fellowship meeting. Now, think about that for a moment. Obviously, again, comparing and contrasting, we have lower rates of availability of Gamblers Anonymous, as well as lower rates of utilization. And keep in mind, again, the element here is, one of the elements here, not far behind, is professional addiction treatment. Again, that theme of relationships building and relationships really being central to the change. Even as you continue down, the next one was a far leap down to life rings, secular organizations for sobriety, et cetera, non-12-step recovery support groups. And if you think about where GA is, that's kind of in that category insofar as it's not as common out there. If you have alcohol as an issue, AA groups are all over the place. I remember when I was working in Maryland, we had exactly 7 meetings. So if you wanted to get to a meeting in every day, you'd have to travel the entire state to get to these 7 meetings. Very different, and which availability certainly makes a difference there. All right. So another quick point to consider about where we want to get to, because very often we get focused on, I want to stop people from dying. I want to stop people from suicide. I want to stop people from leaving their kids in the car while they are gambling. You know what I'm saying? But life is much larger than that. That recovery is not about not abusing my kids. So how do I begin to identify? And so this is also from the Faces and Voices study. They do detail this in much greater detail. I'm just giving a quick sample here. consider that they did a great job of breaking down the difference of when they were in active addiction, up to 3 years, 3 to 10 years, 10 years plus in recovery. And you can see the dramatic change that goes on as I have a place to live. I'm paying taxes. I have my own bank accounts. I'm paying bills on time. You know, these are not treatment goals, but when I do things that get me into recovery, my life practices are different. I go to regular checkups. I get dental checkups. I have primary care provider. I'm exercising regularly. You see the dramatic changes that occur as a whole person, as a life person, as I continue to move towards this thing called recovery. So as context, think a little bit again about where are we trying to get folks to? So if remember I said at the very beginning, what our perception is about change and recovery. If I think an individual is just about not leaving my kids in the car, if I believe that change is just about not participating in domestic violence as my spouse confronts me about my gambling, then I'm only going to bring a client to that level. So it's really important to remember that over a period of time, we're talking about moving our clients way forward beyond that. And when I reclaim a full life, some of these smaller things in the short term clear up. Now, quick question. So what causes an addiction process? Now, obviously there are many, many elements, but it's really important to think about where they are and how varied they are. So you have things that are like biology, like my genes, my biochemistry, my brain, my neurochemistry, the autopilot learning. You have relationships with others, such as isolation, when we started to talk about, but peer pressure, positive or negative, family, the old term enabling, lies, trauma, culture, socioeconomics. There's relationship with myself, the shame, the guilt, the negative beliefs, or even I hate myself. There's my relationship with my higher power. There's hopelessness. And even if you don't believe in a higher power, there's that connection with my personal values. And how does that impact what I do? Now, notice that you can take this as a tool and think about the client that's sitting in front of you and check off which ones of these, A, are present for the client, and B, which ones are they aware of and which ones are they not aware of. And if you think about it from this perspective, by the way, you're also immediately going to be creating what are the effective tools that you want to put in place for this individual in front of me. So for example, if we identify that the isolation is a cause of addiction in the person that I'm working with, what will work for that? Obviously, building connections, building positive peer relationships, building relationships with my family members, and a supportive environment with my spouse or partner. So begin to think about how this also feeds immediately this slide into treatment planning. And you can also be using something like this as a check-in over a period of time to identify what is different over the course of time. I've also used this particular type of a slide as asking the clients to fill it in because it tells me over the course of treatment what have they learned and what have they not learned yet. It can be used in a family session to begin to think about helping the family member to understand that this is not just about my loved one being lazy or crazy or stupid, but there are complex factors that have caused this addiction process. And it's really important for them to understand that to help to ease some of their fear and anger and move beyond that so they can become a positive support once again. As long as they're holding on to their fear and anger and hurt, it makes it really hard for them to listen and be supportive in ways that are helpful. Okay. All right. So let's consider for a moment a little bit of a broader view for a moment. Now, this is a different way of kind of envisioning some of what I was just saying. Notice immediately that there really is a whole person that we want to think about. from biology, from recovery management, from trauma, spiritual beliefs, motivational issues, emotional issues, relationship issues. And so each one of these areas in life will have their own tools, interventions, and practices. So on the top right, you see here beliefs. And out there, one of the most studied and evidence-based tools out there is cognitive behavioral therapy across disorders, okay, which is excellent. And understand how it relates to all these other elements, okay? So remember that we want to, the more of these elements of the whole person that we can get to, the more likely we're going to help to create a stable recovery. It's very easy to get focused on, did they get their MAT? Did they get their MET? Did they get their other acronym of the day? Okay, all of which are valuable. But we have to be careful about any one of them being considered the solution. Okay? The solution lies in giving an individual the room to grow as a whole person. Okay? So let's consider this for a moment. I picked on cognitive therapy to start for a moment. It's a great place to start since it's so well addressed. Consider the beliefs that would be identified, for example, in a person with gambling disorder. I need to gamble. I may have this belief. It may be a belief that is feeding my addiction progression. I've tried to stop, but I can't do it. Remember back to our initial discussion? Very often our clients have a disease of hopelessness. I've tried to stop, but I can't do it. Everything I've tried didn't work. Why is this going to be any different? Okay. Getting high makes my life tolerable. Gambling isn't the problem. I have a money problem. Gambling is the solution. You just don't understand. I can't ever stop gambling. I just need to gamble so I can get out of this hole, and then I'll be okay. Okay. So you see how important beliefs are in maintaining the gambling system and the gambling behaviors. If we don't address these beliefs, they are going to, this last one in particular, if we don't address this belief that I don't have a gambling problem, that gambling is the solution, we're not going to get them, we're never going to convince them to change. You know what I'm saying? We have to address the beliefs in order to change the person. Comma. Let's think about that a little further. Be cautious here that medication doesn't change these beliefs. We talked about treatment plans as a priority. These don't change this belief. Progress notes don't change these beliefs. No matter how good a progress note you write, no matter how many hours you take writing progress notes, it will not change these beliefs in a client. Education on the harms of gambling doesn't fix that problem. You know, some people use 4 days of withdrawal management. The insurance company says, you're cured, go home. That will not fix beliefs. So medical interventions, paperwork interventions, etc., will not change these belief structures. We have a separate problem here that it may or may not treat the core issues. So even if these 4 beliefs are critical, they will not address how to build relationships. It will not address how to establish self-respect, identify my core values, find a bit of pleasure in life, how to build a bit of hope. Okay, so I go back again and again to this image of whether you use the elephant or the flower, whichever metaphor works for you. Consider that you don't want to have just a corner of the person. Okay, cognitive therapy is excellent, and it's a part of a context. Behavioral therapy is excellent, and it's a part of a context. Good paperwork and documentation is important. It is protective of us as a professionals. It is standard of care. But understand where it fits in the whole puzzle to make sure that we address the whole person. So consider for a moment into the future. So we've gotten up to our present moment. We've got our background now. Where are we headed in the future? And how do we keep the individual at the center of our efforts? And I put to you, we're going to start a little bit more, if you hadn't guessed already, with relationships. As professionals, what is our path towards fostering recovery? As we talked, addiction is a disease of isolation. Consider how my beliefs influence the treatment. The attitudes of others around the individual influence the treatment. So we talked already about that, how my beliefs influence the treatment. If my client's partner believes that they will never get better, that is going to affect the attitudes and relationships that they will experience. Consider the relationship issues such as isolation, connection, and judgment, how they influence treatment. So think about those elements on the causal layer. The more I'm isolated, the more I'm going to be sitting alone with my own personal judgments and guilt and shame. The more I'm connected to people who are judging me externally, the more I'm going to feel isolated and separate and alone and shame and hopeless. The more I'm going to have this mirror of other relationships that are telling me that I can never do better. You see how each of these layers need to be addressed. And if you don't address the relational layer, whether that's my relationship to others, relationship to myself, relationship to higher power, relationship to my body, and how I treat my body, it becomes much more challenging. And the more of these elements that we address, the stronger we can approach. So just for context here, consider an individual sitting at a slot machine alone. So addiction is a disease of hopelessness. I've given up. Nothing works. I've got 5 times my annual salary in debt. I'll never get out of this. Hopelessness. It's a disease of shame. I'm a failure. Gambling of all disorders is a disease that particularly gets at I'm a winner or I'm a loser. It's in our language. And what does that do to us as we persist in experiencing failure, 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 loss, loss, loss? Addiction is a disease of isolation. We've certainly touched on that as well already. So begin to see how these all combine to this one woman sitting there in front of her slot machine. Okay. These are going on in her personal mind. These are going on in the relationships that maintain her to be where she's at, in the people that she's pushed away so that she can maintain that relationship and that system as it is. Okay. So one more layer here, or maybe a couple more layers, relates to recovery capital. We're growing our awareness back into recovery capital and understanding how these elements fit. So there are, for example, tools out there that will assess recovery levels of recovery capital. What are the supports and strengths that I bring to the table that will help to make it easier for my recovery and can be used as tools to support me? And some of the things you will see on the right, such as achieving abstinence. The more I am able to clear my mind, the more I'm able to participate in other things, the more I'm able to feel empowered and free and able to make choices that are different. Notice the recovery experience: life purpose, optimism, confidence, positive relationships, citizenship, such as a sense of belonging or social contribution. So catch the issue of layers here, where there's understanding within myself, but then experiencing my relationships, my cultural experience, my citizenry, larger and larger spheres that help to maintain me in recovery or push me back towards risks of recurrence of challenging behaviors. So William White is certainly one of the well-known authors out there and speakers on recovery capital. He really begins to focus on, as part of the recovery assessment tool, some things that related to isolation. I feel like I have meaningful and positive communication with my family and community. I have friends who are supportive of my recovery process. I've established close affiliation with local recovery groups. Hopelessness. My personal values and sense of right and wrong have become clearer and stronger over the years. I now have goals and great hopes for my future. I know that my life has a purpose. So think about this for a moment as we begin to consider again, how do I build into my sessions conversations that will bring meaning and values and connections as a priority, as onto the treatment plan about how to grow these areas and improve these areas in my life. Now, particularly at early stages, the first place we need to start with that as counselors is our relationship with the client. Our role is to foster that individual change. Our role is to model a safe and trusting relationship. How do we begin to talk about the scary spaces and convey the confidence that it's all right to talk about it, that I will help you to get to the other side of it, that it's safe to talk about that here, I'm not going to jump on you. You know what I'm saying? Like they may have experienced in the shame and relationships of their past. How do we develop and facilitate the development of these relationships in their recovery systems and supports? You know, we already talked about 12-step, which is certainly one approach, but do I do only group therapy, individual therapy, or do I build in group therapy? Group therapy is an important and valuable tool where a counselor can help to facilitate these relationships, help an individual to know that I'm not alone when I so often feel like no one else has experienced what I'm experiencing. I'm worse than everyone else. I'm fatally unique. Maintain cultural competency and context. That is one of the roles that's really important to us as counselors, understanding how men and women see things differently in the world, understanding race and culture as they relate to issues, understanding how I, with my personal demographics, relate to this individual that's sitting in front of me with their personal demographics and cultural history. Okay, what context and history am I working in the context of? And how do I have the competency and develop the competency to work with diverse cultural experiences? How do I begin to identify my therapeutic alliance? Because that is one of the key elements that will help us to develop the relational supports. So key elements that you may have heard before in your career: empathy, that I understand you, that I hear you; warmth, genuineness. This is really important. Actually, working with a student, this is part of her doctoral dissertation. That genuineness element for addiction is particularly important. It's not just love them and appreciate them for everything that they do, no matter how bad it is. Genuineness also involves having the respect to say, I see where you're at, I still appreciate you, and I want more for you. And I know you're able to do more. So it's not about shaming, but about caring enough, having the warmth and empathy to say, I see how this piece is still making you struggle, it's still painful for you. And I'm going to have an open communication to help guide you there. And this is a safe place to talk about that. You may not be able to talk about your fears with some other people, but talk about that here. You may not be able to talk about your shame elsewhere. Let's talk about that. Let's move beyond that so that they no longer control you. Because these beliefs and fears and shames and guilts, if they're not addressed, it's kind of like baggage that you're carrying around for days and weeks and years, and it gets heavier and heavier. So we need to have a safe space to unpack that a relationship where you trust me enough to do that. When people have looked at the confidentiality issue, the Supreme Court has actually weighed in before and said that actually the counselor relationship is less like that of a physician and more like that of priest penitent. That it is an important part of our role to talk about the places of shame and woundedness and guilt. That is a little bit different than is handled in some other disciplines. And so we need to balance our support with the courage to alter these difficulty in emotions. And I certainly add to this time and consistency. Think about your closest relationships in your personal life. One of the things that's most common there is time. I've been with this person, I've known this person for 20 years. Relationships don't happen in 2 sessions. Relationships happen over a time and consistency and trust that develops over, I faced challenges with this individual and we've gotten through it together. I faced challenge with this individual and they have had the courage to have my back and support me through this process. Okay. Emotions. As professionals, it is part of our path to move from these external interventions to managing the internal world of the individual. This really moves us into the world of emotions. And I'm going to give one more example here is a context of stress management. So imagine for a moment that you woke up and it's 8 o'clock in the morning and you're tired and you have no stress. So you say, you know what? I'm tired. I'm going to roll over. I'm going to go back to sleep. So another hour goes by and things are a little different. You look around and you say, yeah, no stress. I'm going to hang out. I'm going to roll over, go back to sleep. Another hour goes by. You start to say, you know what? I'm getting a little hungry. You know, maybe I need to use the restroom. You know, maybe my boss is going to get mad at me because I didn't show up to work yet. So I guess I better get up out of bed. I'm going to go to get something to eat. So I get up out of bed. I go to get something to eat. I go to the kitchen and I look in the refrigerator and I say, oh, there's no food here. I guess I better go get a job so I can get some money, so I can get some food, so I can eat, so I don't die. So you see what starts to happen here. Stress is actually a motivator. Stress moves us into further and further actions because without it, with zero stress, we'd actually have zero productivity. We wouldn't get out of bed in the morning. So the definition of this is called eustress. Eustress is basically defined as the amount of stress. Notice it's not the content, it's the amount of stress that builds to motivate us to move forward in life. At some point, we reach this thing called peak performance, and any additional stress beyond that is what we call distress, which is basically where immediately our productivity goes down. This is also where most of our folks with addiction are living, in the process of overload, in the process where it is creating stress, it is a process where it is creating physical symptoms and ulcers and heart attacks, et cetera, et cetera, et cetera. Okay. Now, I would encourage you to think about this, that with the context of stress, it is not about getting rid of stress. We don't want to get rid of stress. The modern thinking is about stress management. How do we keep that stress, I say, in this kind of target area here? We don't want to be at that peak performance level, because if we do, the daily changes of stress will ebb and flow and we'll be into distress. So we want to stay just a little bit lower than that, but we don't want to be so low that we're not being productive. So we're going to use this as a metaphor to talk about emotions as we continue on in this conversation. How do we begin to have not too much, not too little, just right? How do we begin to have emotional management as a balance there? Okay. So as we're going to continue this discussion into emotions and apply that into what are the tools to make that as an effective tool for change. Once we have a solid relationship with a client, then we have a safe space to deal with these emotional elements. So I'm going to break here for a moment, and we're going to pick back up live in just a moment. I'll see you on the other side.
Ken, that's great stuff.
Thank you.
You know, it's so funny. I almost, with these recordings, I almost feel like I'm constantly watching you live anyway.
Good.
It brings that feeling. So wonderful done. So much great stuff. And I'll let you continue with the flow. That was a seamless transition. We're good to go. I see your screen perfectly. Stages of change. I will put my video dark. I'll stay muted and I'll be checking the chat room, and I'll see you back when you're done for Q&A.
All right, let me try to do one more thing real quick here. I just realized that when I switch screens, that lost my chat. And I want to be able to see what y'all are chatting so I can interact with y'all as we're talking too. Okay, much better. Okay, good. So, good. So, a couple of things to think about there. So, thank you all. I know I've been covering a lot, and I'm going to shift gears just a little bit now as we go from the broad context. And I did see the question, by the way, come in about how we continue to build an understanding of the cross addiction, and particularly in the gambling side, we end up having to be particularly aware of the mental health and SUD side, and they're still growing their awareness of our gambling side. So there's a lot of things, there's a few things we can do to support that along the way, as well as some of these types of conversations, right down to the practice of where are we at with helping to translate across the world. You know, there is so much more funding and so much more research on the SUD side. And we were talking earlier in the morning session about how so much less funding goes on to our gambling side. So if we are underfunded, we are also going to be under-researched. And so we end up kind of piggybacking on some of the conversations of what is research from general addiction rather than specific to gambling. This is a significant challenge for a number of reasons. And so some ways we can begin to think about that, and I'll save some of my conversation to the Q&A piece for that, just because I have worked at the state level before, and so there may be some things we can do on the policy type of a level. So one of the things to kind of think, we started this conversation a little earlier this morning, that, well, is the research out there for motivational interviewing? And absolutely, there are tons of research, and it's very solid on the SUD side, on the addiction process side, and there's no reason to think that that would be any different for the gambling side. This is not a something unique. It's kind of like saying aspirin works, but we've never tested it for 25-year-old white males. Well, there's no reason to think it would work any differently for 25-year-old white males than for others of other situations. So I'm not going to spend a ton of time on this particular process, except to say that two things. One is that emotions are the motivators, are the drivers of that motivation. And so if I was doing this in a 6-hour talk, we can begin to think through, and you may begin to get the sense of how, as I talk about emotions in the coming slides, they will follow patterns, by the way, also of the motivational stages of change that are in a process setup. Okay, so it's real important to begin to help folks to move out of a lack of awareness. So I agree, the funding problem there, so that would be a pre-contemplative stage issue. We have, I remember doing gambling trainings where I'd be there for substance use counselors, and I'd say, how many gambling clients have you ever treated? And I'd have a whole room of 50 staff, 50 counselors with caseloads of 30 each, and not a single person had ever had a gambling problem client. Now, you all immediately understand the issue here, that if you have an average of 15% of those with an SUD have a gambling problem, they've all had a client with gambling problems. You know what I'm saying? So the pre-contemplated, the lack of awareness of an issue really drives these elements. So think about how these relationships all continue to grow here. Now, I'm going to talk a little bit about emotions, and I'm going to start here from the context of just a kind of basic 5 spheres of emotion: fear, anger, joy, compassion, and sadness. Now, notice how immediately there's some negative connotations here. And some of you may say, oh my gosh, I never get scared. I may even have that t-shirt, no fear, never fear. I'm strong, you know. I'm a guy, I never get scared. Or I had a client recently said, oh, I never get angry. And of course, the response as the therapists among you are sitting there saying, yeah, you never get angry. And you already know this person in a domestic violence situation has experienced anger in their lives. Okay, so we begin to think about these circle of emotions and begin to think also about them, just as we started from the conversation about stress management, that it's not about never having emotions. I was just recently asked, actually yesterday, how do I get rid of all emotions and be completely numb? It's like, no, you don't want to get that. Okay. So if I got that wish, if I had 0 fear, I would suddenly be very impulsive and I'd be about to die. I'd be about to step out in front of a car because I'm not afraid of it. Okay? Fear is there to protect us from danger. Now, what about the reverse? If I have too much fear, you're suddenly going to get that deer in the headlights look. And you're also about to die. You're about to get hit by that car, right? So fear is an important emotion. We need to have it in balance in our lives. Not too much, not too little, just right. Now, I'm not going to go around and do that same thing with each and every one of these, but you can do that same process with each and every one of these 5. And that's why part of why these 5 are what they are. You know, anger has a certain negative connotation, but the same principle. If I have too much, it's aggressive. I'm going to go punch somebody. If it's too little, I am going to be passive. I'm going to get stepped on. And codependent. So think codependent versus being bullied, being robbed, being conned in the gambling world. Versus somewhere just in the middle, assertiveness, having a drive, knowing what I want, being willing and ready to ask for it and communicate that and move towards my needs getting met. Can you begin to see how each of these elements of emotion are critical to having a whole person, are critical to having motivation and drive and being steered in a full and rich life? Okay. Now, for many folks, particularly for gamblers, we tend to be up in our heads. So we've got to begin to think about how do we draw down to the emotional world. And so for this reason, for many clients, I will start with the conversations with just these simple 5, 10 types of emotions. It's just enough to begin to identify, are we in the anger world? Or are we in the sadness world? You know what I'm saying? So start simple to begin to bring awareness and identification of emotions. Now, if I have somebody that's a little bit higher functioning or has practiced a little bit, you can begin to use a feelings wheel that is a little bit more robust, a little bit more detailed. There are dozens of feelings wheels out there that you can use. This one is organized in a certain way to begin to think about this conversation about a range of the emotion, from too much, too little, from what it looks like when it's out of balance to when it's in balance. So, for example, back to the fear example, when fear is balanced, you think about somebody who's brave and you know, courage. Courage is not the absence of fear, but the brave, the strength to do what you're going to do despite it. Having grit, having valor, having perseverance and endurance. You see how important that is for the addiction process, to be able to say that I'm going to persevere in my efforts to recovery. And the reverse is also true. How do I deal with the fear, that panic, that terror, that, oh my gosh, somebody's going to find me out, the hiding all of our secrets? Okay. So again, we can go around with these all the way around the circle. The next tool that I would use way to use this is helping an individual to identify where they're at. So I'm not going to ask you to put this in the chat box, but check yourself right now. In the last 24 hours, can you pick 3 emotions out of this feeling wheel that you have had, that you have experienced? Okay. Excellent comment, Judah. I will circle back to that. So the building this conversation about where we're at and which emotions we're having. So I'm going to add more layers to this. So the next layer is, let's apply this, really drill it down into addiction process. So the first one is fear. So what are some of the specific fears and imbalance and balance when we're in this process of taking a look at our emotions? One is the fear of getting caught, but also the flip side of that is having the courage to ask for help. I may be feeling helpless and hopeless and stuck, but can I also have a vision of the future? Can I build a vision of hope so that I know that where I want to get to in my recovery and what are the steps to get there? Rather than sitting with my arms crossed, being angry at the world, saying, I've tried all this thing, nothing works. What are you going to do for me? I've got 5 times my annual salary in debt. There's nothing you can do except to bail me out and declare bankruptcy or suicide. All things we talked about earlier this morning. Okay. Again, I can go all around here. Think about the ways in which addiction is isolating. We've talked about the ways in which, as I get really, really pushed into my addiction process, I can become very, very self-focused. We think about narcissism, but also just the self-focus. I'm so busy trying to think through, where am I going to get some more money? Who owes me some money? Where can I juggle to get some money today? If I borrow this money from here, not steal it, but I'm going to borrow it from here so I can pay off this one, so I can, it's a whole lot of thinking going on there. Okay. And sadness, respect, and grief. Do I believe that I am worthy of recovery? I fully agree with what was said this morning. This process of grief as really being central to this issue of particularly gambling disorder. So it is, as I said a little bit earlier, about this difference of winning and losing. If I have a marijuana use disorder, that's not about winning and losing and being a winner or a loser. You know what I'm saying? This gambling really draws that very carefully for us. By the way, thank you for sharing some of your emotions there. Notice how with a group like this, we can begin to say, wow, I really do have a range here. And so we've got compassion and joy. So that's on the happy side, as well as the courage side. Hurt, joy, and focus. So you've got some pieces that pop up on the different sides of the circle. I didn't pay them to put that in there. This is coming up in the next slide. Okay, excellent, wonderful timing. So if anybody else wants to share some of yours, you're absolutely welcome. Although, like I said, I'm not going to put you out there in the discussion there. All right. Oops. So as we begin to identify what are some of these areas, we can begin to identify what are some solutions that will be appropriate to these emotional areas for growth. Now, if I have an excess of an emotion, my work is not to do more of that thing. It's about how do I bring balance into this circle. Okay, so for this layer, I just want to begin a little bit of a conversation to build a bit of balance. So if the lower left, back to fear, if I'm frozen in my addictive pattern, you know how our clients have been doing this, and I've been doing the same cycle of steal money, use, gamble, lose the money, go back and do it again tomorrow. So particular problem here. So if we begin to identify some of the whys, what are the causes, what are the motivations, and how do we begin to build some of those alternate solutions. In a larger perspective, you can also begin to think about rest and sleep and journaling, things like that, that fit into these types of areas to manage that fear. What about the lack of confidence? I don't believe that I can change. I don't have a hope and vision that I can get out of this. So how do we begin to help them to build a vision? So for example, there's a tool called a vision board. So you can use this in practice. So I'm going to sit down with a client and say, where do you want to be in 5 years? And let's create a vision of that. What do you want your family life to look like? What do you want your work life to look like? What could, even though you don't see how to get there from here, let's create a vision about where to get to. And then we can begin to work backwards to, well, what's one thing you can do today to work towards that? Okay, and notice what you're doing there. By creating a vision of it, you're creating hope for that element. Just by practicing that practice. You're creating empowerment to believe that I can make such a change. Some things to think about also: joy. When I've lost everything every day, where is my joy? Where is my pleasure? I may be seeking pleasure at the beginning of my gambling, on my occasional win, but near the end, or after a while, you get that numbness there, where even if I win, it's not enough to dig me out of the hole. It doesn't quite answer the problem yet. So you can begin to see how we can go around each of these 5 and begin to identify self-defeating beliefs and address those from a cognitive behavioral perspective. So by the way, these are also got to hit on some of the major theoretical orientations. Can we begin to look at our roots and underlying issues? Can we begin to look at our belief systems? Can we begin to look at the heart? Can we begin to look at the value systems that we bring to and Rogerian therapies as well? So each of this is also an integrative model of treatment, by the way. So a good way to think about the different models of treatment when you're working with clients. Could it be that great question there. So our own sense of self-doubt and feelings of not being worthy of love, absolutely. Absolutely. That was one of the first questions I asked. Remember that on the first slide, saying, we as counselors, do I believe that I'm worthy? Do I believe the client can change? Because if I don't believe it, how the heck am I going to guide you there? You know what I'm saying? But on the reverse, to the extent that I have depth and strength and solidness in my recovery, or my sense as a human being if I'm not in recovery, the better I have that sense of self-worth, of courage, of self-respect, the better I can help to guide you there, whether or not I am in recovery. Okay? So real important. Great question. So shift gears here. Adding one more layer, begin to think about these as strengths and weaknesses. Okay? So going back to the comments for a moment before here. So hurt, joy, and focused. So you begin to think about where are there elements which are strong and elements that are weak. Okay, as you begin to think about the range of emotions that evolve. And I can't do much about what's already strong. I can't get you to stop gambling. Think about that for a second. That's a longer conversation. But it's really hard for me to get you to stop gambling. However, I am happy to help you create a vision of a life that's worth living and help you to find the steps to get from here to there and give you the hope that you can get beyond there. And so that motivational enhancement therapy, right? So I'm going to give 2 quick examples just to kind of bring this cycle home. So you have a 32-year-old male that's a sports bettor. Begin to think about the excess. You begin to think about that sense of drive. Think about that sense of passion, that, yeah, I got this. I'm going to win. I'm going to, no matter what, I'm going to, no fear, I'm strong. Even that emphasis of I'm a winner, and that you get that charge, I won the game, et cetera, et cetera. But do you also get a bit of that insensitivity? It's about me. Do you get a bit of sense of that lack of value. I'm caught up in the rush of the win rather than the rest of the elephant. Okay. Now, just going to bookend this for a second. I'm going to give one more example. Go back to our female gambler, 52-year-old female using slot machines, stealing from her church and to fund the gambling. And here you see this woman sitting here in front of the slot machine, kind of just kind of zoning out. This is not about a rush of emotion, not about a rush of passion. There's a lack of that depth of emotion that we had in that male gambler. In contrast, though, with this case, and this is just an example that this is, I'm creating two avatars to compare and contrast. She may have deep sense of guilt and shame about having stolen from the church. You know what I'm saying? All about the escape, absolutely. So wallowing in her guilt and shame and isolation there and withdrawal. She's no longer able to get beyond that internal rumination. I'm just going to sit and think about this and stew and stew and stew and stew and escape and escape and escape. It's not about that rush of emotion. Okay, you feel the bookends here. So with this particular type of client, I'm not going to do the things on the right. So much as I'm going to see how can we build a bit of courage and vision and bring a little bit of pleasure back into her life, as compared to the fellow before who, on the reverse, I'm not going to build him more passion. How do we build a little more caution and values and understand what's this doing to your family? What's this doing to your friends? How do your kids respond when you're out there and gone all week? You know what I'm saying? So you begin to strengthen the areas that are weaker. Okay. Steal from the family. Stealing from God is another issue. Absolutely. So spirituality is another key element there. I think I'm going to have a second to come back to that. I'm going to circle around the circle one more time, one more layer. I know when I've done this type of talk before, I've gotten asked for more and more tools, and I'm going to try and cram in as much as I can. So I'm going to talk a little fast, but you can get this a little bit more in depth in one of my books, but there are a range of tools, okay? And there'll be tools that you would then pick for each and every one of these 5 areas. So for example, if there's fear, there's specific tools you can use to work with fear. So for example, rate my fears on a scale of 1 to 10. If my fear is a 10, what can I do to make it a 9? What sorts of things could help for me? Where would I like it to be? Well, I'd like it to be a 5. Notice what I just did there. In 2 seconds, we just motivated this person to say, this is what I want. I'm not where I want to be. Well, what are we going to do to get from a 10 to a 5 or from 10 to an 8? How about in the next 2 weeks, can we get from 10 to a 9? Exposure. Exposure is a behavioral technique that's sometimes used. So for example, exposure to slots, exposure with response prevention. Another one that sometimes I call it grandmother hug. It's a visualization exercise. Imagine that grandmother or auntie, that safe space in a relationship, that person just give you a big hug and make it all okay. You can think about affirmations such as, I'm courageous, I trust, I'm flexible. Okay. And so I'm not going to spend as much depth on each of these, but you begin to get a flavor that for anger, I can begin to identify sources of anger. You begin to do breathing exercises, physical exercises, etc. Assertiveness training. For pleasure, you can begin to identify what are 20 things I like to do. What is one thing I can do today that will crack a joke or smile? Do I bring that into my programs, into my treatment programs? Affirmations are very different. Like, how do I be able to get a little bit of playtime? And I'm worthy of some playtime, healthy playtime. I'm not talking about gambling. Relationships with others. How do I begin to have a bit of compassion, that sweetness in life? How do I think of step 12, that donating, that I have enough abundance that I can donate, I can volunteer, I can give back to the world? How do I begin to also work with values and values clarification, differentiate between my needs versus my wants? So I may have some debt, and so I may need to focus for a minute about what are the things I really need versus the things that I want and I need to set aside for a little bit or work on later. A gratitude journal. How do we begin to develop apologies where appropriate and make amends as appropriate? So there's a lot of tools for each and every one of these to support all the way around the circle. Now, I'm going to go shift gears for just a second here, well, for 2 minutes here, and talk about the brain. And I know, no groans here. I know I'm starting to get hit between here and lunch. I'm going to talk about the brain right before lunch. Oh my gosh. So this is a quick sample of the brain. Don't worry, I'm going to make it make sense. So this is a quick image of your brain. Okay, so you have two brain pathways here. You have one cell reach out to two other cells, reach out to two other cells. And this is obviously much more complex than this, but for conversation's sake, I decide to gamble, I go get some money, I drive to the casino, I lose, I win, I lose, 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 I go home and I'm upset. Now, that was so much fun. We go down that brain pathway. That was so much fun. I'm going to do it again tomorrow and again 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 and again. All right. So you begin to get the picture here. This is the disease model of addiction. So the disease model of addiction says that addiction is potentially fatal. We know about the risk of suicide. We talked about that earlier this morning. Okay. We know that is chronic. So you see how we just developed a brain pathway here that, you know, if you develop a pathway and carve some water, eventually you got a Grand Canyon. Anybody been out to the Grand Canyon lately? Is it still out there? You know what I'm saying? Once we've got a Grand Canyon carved in here of a certain memory formation, this is memory process, by the way. It's not going to go away. The Grand Canyon is always going to be there. This is the conversation about that if I stop gambling and then start again another day, I tend to pick up quickly to where I left off. And the third element of the disease model is that it's progressive. So you see how it's a drip of water, it's a stream bed, it's a river bed, it's a Grand Canyon. It's progressive. The longer I do it, the worse it gets. So you can't compare someone who is in early stage of addiction with someone who has practiced this for 5 years. Speaking of which, what's the average time that somebody comes back into treatment? You know, I maybe have been doing my gambling a little bit less. Average is 3 to 5 years for women, particularly for slots. 10 to 20 years for men, particularly other action types of gambling, casino, sports betting, etc. So what can we do with the Grand Canyon that we can't deal with? One of the things we can do is to put a dam there and say, we will no longer go this way to the Grand Canyon. Instead, I'm going to go to treatment and do recovery behaviors. So you go to our treatment program and you spend a week there, and the insurance company says, you're cured, go home. You are no longer needed. Now, this is not a trick question. Which of these two brain pathways is stronger? The recovery pathway or the addiction pathway that I've been practicing for 5 to 10 years? This is not a trick question. You too can understand brain science. You see what's going on here. We have learned behaviors. This is not unique to gambling. This is how we learned our times tables. This is how we learn many things in life. As you repeat again and again and again, we learn this. Now, why am I spending the time on this brain piece here? So I'm transitioning us forward from emotions forward to where are we going to get into process. By the way, this is one of the reasons we think about drug addiction as an external chemical. By the way, as we are going through this mental process, we are also firing off, there are 200 different neurotransmitters. So we are processing the anticipation neurochemical and the excitement neurochemical. You may know of that as adrenaline, the hope neurochemical. Then you got the rush chemical. Then you got the, oh, shoot, I hate myself chemical. So we actually, even within gambling, we have an internal chemistry going on that is an internal chemical set where we become physically addicted to the chemicals of addiction internally, not just externally. So one other comment to think about here is that we want to do the reverse of this. We want to build those recovery behaviors. And so we want to begin to apply that to practice, practice, practice. So think about the things that I was just saying in the slides before about emotions. Identify the problem areas in life. Identify the practice areas that you can practice and practice and practice until these recovery areas become strong and can offset those weak areas where we've developed addiction. Okay, so got it. So we are summarizing here just that remember that we can change. This individual work is central to our work, and we need those external supports. And so moving that one layer further, so we talked about the individual. Think about how we put in practice things that support us with family members. And I didn't forget the earlier question, how we begin to put that in practice to get funding and larger supports. So for example, as we begin to give back, as we begin to get stable in our recovery, can we educate our legislators? Can we educate our drug and alcohol representing agencies at the state level and federal level? Can we begin to have practice and coordination, for example, with the other state and national agencies? Do we stay only with the National Council, or do we begin to talk to folks at NADAC? Do we begin to talk to folks at NASADAD? Do we begin to talk to folks at the other national agencies and have cross understandings of the roles that we play together? One thing I'm going to leave you with, although I'm going to pause here, is think about one thing that you've learned today that you plan to use on Monday. We've covered a lot of materials, and I don't want trainings ever to be something that you stop and then don't use again. So think for one moment, what is one thing you learned today that you're going to put into practice? So we're practice what we preach, practice it on Monday. So for example, I'm going to identify a feeling wheel and ask a client to identify their feelings. I am going to identify one treatment tool that will work with one problem area that I'm working with a client on Monday, etc. As we do this, we can get away from, we still need to do progress notes, but remember that as we come back to the heart of the person, the heart of the relationships, and the heart of who we are as people, and become more rounded and whole people together, the better we'll be able to be functioning together. References are there. I love this stuff if you haven't figured out. I'm going to again throw my contact information up there. You can also go to my website. There's all sorts of tools out there. You can download them for free. And I'm not sure if I missed any other questions coming in. If not, there's some other things we can begin to work on there. And yes, feel free to either chat in thing that you, by the way, when you chat in that says, I'm going to do this on Monday, you are also committing to something. You are also making it more real for yourself. This is what we're doing with our clients. If we do this with ourselves as well, we become that much more likely to actually follow through, rather than just make a plan and think about it some more and think about it for 5 years. Put it into place. What's my actual step that I'm going to do today, do Monday, et cetera, et cetera. So I'm going to catch a breath and keep watching the chat box for questions and other questions as we may come in here.
Great. Ken, great job. So much good content. I think about one of my favorite folks, a social worker I love to follow, is Brene Brown. And she talks a lot about courage, compassion, loving yourself so others can also love you, right? And it's so critical about that feelings of worth, right? Self-worthiness. And a lot of people just don't feel as if they're worthy of love and belonging and care and connection. And that's kind of what prompted that initial comment. I put something in the chat. I just wanted to just kind of reemphasize, because I think about Dr. John Grant from Chicago is someone that I heard talk about this at a conference. And he talked about the concept that what initiates the gambling problem is not always what maintains it. Absolutely. And such a critical point. You've touched on so many things, and you can kind of see from that perspective what you've touched on today of how that can be the case. People, when I started gambling, I'm in recovery over 11 years, and I share that very openly. I gambled for action at one point, but then after September 11th, I gambled for escape. Right. And so you can see how it applies.
Absolutely. And that's very much the case. When I talk more about motivational enhancement, very, very often I am drinking or gambling for fun, and it's pleasure and it's enjoyment, and then I start losing, And then I start isolating rather than gambling with my friends. And then I go down that rabbit hole where I'm isolating, and now I'm gambling because I'm trying to pay off my debts. And now I'm gambling just in the ozone, in oblivion, you know. So it's really a changing, evolving process.
It is. It is. Pat Healy asked, what was that medication again? The medicine again you had mentioned?
Medicine.
Was there a medicine you had mentioned? I don't recall. Maybe it was. I know Dr. Grant at one time had done some studies on L-acetylcysteine, I believe, or N-acetylcysteine, I believe. Nothing's been FDA approved, but perhaps, Pat, that's what you're thinking of.
The N-acetylcysteine is the most commonly one used for gambling. We've used it for years. It's had some good effect. There are a number of medications out there, but for gambling, they've had very small effect sizes and small numbers of patients. The one that seems that is most close to being appropriate is naltrexone. So that's well known in the drug and alcohol world, but it is showing some promise in the gambling side as well. And I'm not positive about the spelling. It is an N and then acetyl, A-C-Y-T-L-E.
A-C-E-T-Y-L, I think, and then C-Y-S-T-E-I-N-E or something like that, N-acetylcysteine. Yeah. I know it's easy to Google, so you're right. I struggle with that one as well.
Yeah, these long names. So
let me just also just remind people, the evaluations are found on ccgnjconference.com, the website there. They were also sent at the top of this chat at 10:55 a.m. The link for where to find the evals, so you can find it there. And also, you know, Dan Smith, I did appreciate his acronym for stigma, stuck tragically. Oh, where'd it go? Hold on, it moved.
Sorry.
Stuck tragically in the
grief of my addiction.
Grief of my addiction. It moved after the screen share stopped.
Sorry about that.
You're good. Listen, we're right at 12:15 now. Ken, you did a great job. I appreciate the content. I think judging by the interaction and just the feedback, people really enjoyed it. I want to thank you for being here and being a part of our 39th annual statewide conference. You know, one other thing, we have a moment, right? Let me just take a minute here because Steve Block did ask a good question. And I don't know if you addressed it earlier, but if you did, I apologize. You know, what can we do to get problem gambling included in the addiction and recovery definitions? Seems addiction only means SUD in the minds of the general public. Anything more to add to that?
Yeah. So how do we begin? So answer the question with the question. We're starting to build that. It's getting commonplace now that drug and alcohol programs will ask at least some screening questions on gambling. Yeah. So they're quickly going to find that now that I've identified a gambling problem, what do I do with this person? So they're going to quickly start coming to us. And so we need to be able to be prepared to do cross training and to share that information. And we have been historically such a smaller focused field. So how to begin to make sure that we go do conferences at the addictions programs as well, so that they get those trainings as well on their side, rather than expecting all of them to come to the gambling training because they're in pre-contemplation. They don't believe that they have a problem, you know? So, and then helping and finding, we really need to find a good champion in the legislature, state or federal. And I know of some folks out in the world there that will be helpful, shall we say, in helping to steer to make sure that there is some funding dedicated to gambling and certainly gets attached to. So when we expand casino gaming, for example, in Pennsylvania, we get 0.002% of the tax revenues from casino gaming goes to prevention, intervention, and treatment for gambling. That's a tall order for one small thing. And notice I didn't say research there.
Right.
So it is a process, but certainly to continue good advocacy to educate legislators as well, because they're controlling some of those purse strings.
Great. Well, thank you again for your time, Ken. We're going to let everyone break for lunch. Remember to visit the resource room, the networking room. Come back to the link that's on the email you received at 12:45 when Luis Del Orbe from the council will deliver his plenary session. Ken, thank you very much. It's been a pleasure. And I wish you all a happy Friday. Continue to enjoy the conference.
Thanks, everybody.
Thank you.